Hi, I am Jenny, and I chose to do my case study over Rickettsia. I actually found a pretty interesting case study on it. Ended up being and these are just her overall. She didn't present with these initially, but overall patient information. She was 43-year-old female. Showed up with general malaise, fever. They thought acute kidney injury, hyponatremia, and eventually she did develop a rash. But 3 days prior to the initial ED visit, she did visit an urgent care, and they pretty much sent her home with antibiotics because they thought that she had a UTI. But 3 days later, she ended up in the ED, again with the general malaise and hyponatremia, and the patient history they got from her. She did have adrenal cortical carcinoma, and which was treated by adrenalectomy, and she does have adrenal insufficiency. Current drugs that she was taking for this was the adjuvant mitotane, hydrocortisone, and fludrocortisone. So initially, due to her elevated creatinine, then decreased sodium, both urine and serum, they came up with acute kidney injury, secondary to hypovolemic hyponatremia due to the adrenal insufficiency, which they kind of thought was due to the fact that she had stated she hadn't been taking her stress dose of glucocorticoid after becoming ill. Also, her WBC was non-elevated. The repeat UA was not consistent with the UTI as urgent care had initially thought. So they thought an infection was unlikely. The patient was admitted to be monitored for her sodium level because it was at 123. She was given 1 liter of the lactated Ringer solution. And after administering that, they did have a slight increase up to 131. So the day after she was admitted from ED, her fever spiked to 102.7. A physical exam then showed the purpuric blanching papules on her shoulders, scapula, and humerus, which a rash on the shoulders is kind of atypical. It's normally on the extremities. They thought maybe a drug reaction, possibly, so a dermatology consultation was requested. The integumentary exam did reveal a 4-legged tick that was under her left breast fold. They said it had the white spot on the back, so it was likely a Lone Star tick by appearance. Of course, after that, they did order a serology panel for a tick-borne illness. Of course, that came back with IgG detected, so they confirmed the Rocky Mountain spotted fever diagnosis. They started her on oral doxycycline, 100 milligrams every 12 hours for 10 days. The next day, she became hemodynamically stable and was discharged. At her oncology follow-up 21 days after the discharge, she had a dramatic improvement of fever, of the rash. Her residual fatigue was still hanging around a little bit, but the hyponatremia had been resolved completely. So just a little bit about Rickettsia. It is an intracellular parasite. It's gram-negative cocobacilli. It is arthropod borne. You get it from a tick bite. And it is the etiological agent of Rocky Mountain spotted fever, which causes the direct vascular injury. So the classic triad of symptoms is the fever, the rash on the extremities, and tick exposure. Other common symptoms are headache, decreased appetite, vomiting, diarrhea, confusion, headaches, body aches, bleeding, edema. Yeah, okay, headaches was on there. So how it infects the body, our Rickettsia infects the vascular endothelial cells. That results in an increased vascular permeability, leading to the edema. It's letting more through than it should, which leads to the hypovolemia and the hypotension. In response to the hypovolemia, the kidney releases the ADH, causing the body to retain too much water. It also spreads throughout the bloodstream where it can replicate in the organs. So the endothelial cells also play a major role in the blood fluidity. So when damaged, they can trigger the fibrin formation and platelet adhesion and aggregation. So it can also kind of cause like coagulopathies. Typical lab findings for the Rocky Mountain spotted fever is hyponatremia, thrombocytopenia. You have some increased liver enzymes, and it's possibly an elevated PT and PTT. So I did find that the kind of gold standard for testing is the IFA, which happens to be, I work for Norton Healthcare, which is what they use as the IFA. They send ours to AREP. So I thought it would be neat to, I just kind of went to their site and printed all the testing they do. They do 3 different ones where you can just do the IgG or just the IgM, but most commonly they'll do both, as you normally need both. So the collection and prep, they just use, the gold top serum, the SST tube. You separate the cells ASAP or within 2 hours, and then you transfer 1 milliliter into a standard AREP transport tube, and it is refrigerated. You do need to mark them acute and convalescent. They want, the initial specimen acute, and then like 2 to 4 weeks later, they want the convalescent for the IgG. Stability, it's ambient for 48 hours. Refrigerated, it's good for 2 weeks. It's up to a year frozen, but they don't want repeated, thawed and frozen. Turnaround time is 1 to 3 days. The reference range is for the IgG and IgM, both is less than a titer of 1 to 64. For the IgG, so the less than 1 to 64 is negative. When you get the 1 to 64 to 1 to 128, it kind of suggests a current or past. And then a 1 to 256 suggests, or greater, suggests a recent or current. And then the IgM, 1 to 64 is negative, and then 1 to 64 kind of suggests greater. 1 to 64 or greater suggests current or recent. So in conclusion, just with the classic triad of symptoms only presenting in 3 to 18% of cases at the initial visit, Rocky Mountain spotted fever can be easily overlooked, especially when pre-existing conditions have symptoms that mimic those of our MSF, which in this case it did, but they did that physical examination and discovered that hidden key that had just been there all along, that tick. That is my works cited, and thank you.